Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about new treatment options for prostate cancer with Dr. Gabriela Spilberg. Dr. Spilberg is an assistant professor of radiology and biomedical imaging at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Gabriela, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
So, my area of expertise is called nuclear oncology. This is a domain from nuclear medicine where not only we're involved in interpreting scans and looking at images, but we're also using the information of the imaging to tailor treatments in cancer care specifically. We're deeply involved in the care pathways from these patients, and we'll leverage molecular imaging techniques to create treatments. So taking a step back just to understand what this molecular imaging means, this is a type of imaging where very small amounts of radiotracer or radionuclide, which are radioactive substances, are injected in a intravenous, in a peripheral vein, just like any regular IV. And then the patients wait for a little bit, and then we image them with either a machine called PET or SPECT, where we detect this radiation outside of the body to try to understand what is happening on a cellular and molecular level rather than just anatomic imaging. At the end of this, we also acquire a CT scan, and then we fuse those images to create fusion maps. So we have the PET imaging, which is really a picture of what's going on in a much more detailed level in the cells, and then the CT and these images with the maps will show us where the problems are. And then based on where we find these problems, then we use those that information to change the molecule that we use for the radioactive purpose into a treatment one. And then we target the same areas we imaged now to create treatments that attack those cells and target in a very specific fashion, so you don't have these therapies going to other places, and then you really can perform state-of-the-art targeted precision medicine in its best form, really.
So that certainly sounds very interesting in terms of using a radioactive tracer to map out where a particular issue is, whether it's a tumor of some sort or a cancer, and then using that same technology, adding on some radioactive tracer that might actually be able to deliver therapy to that same imaged area. So I want to go back and talk a little bit more about what are the kinds of cancers that you can actually use this technology for. Can you help us to understand that?
Sure. That's a great question. So in 2024, molecular imaging can have many different approaches. So one of the approaches, which is an older one, is when we're looking at metabolic imaging. Metabolic imaging will look at the amount of glucose cells are using. So we get a molecule that's analog to a glucose, a sugar molecule. And then we attach a radioactive particle to that. And then we inject in the vein. And then typically cancer cells have a higher replication rate than normal cells. And therefore they're hypermetabolic, how we call as a technical term. And then when we inject the radiotracer, we can map out areas of hypermetabolism that should not have that hypermetabolism, and they still have normal size. So the bigger advantage of this technology over conventional CT or MRI is that we're not looking at anatomic changes, but rather metabolic changes in structures that may look normal. And then besides the metabolic imaging, we're also looking at receptor expression. So receptor expression for neuroendocrine tumors, for example, we use somatostatin receptor type 2. For prostate cancer, we use prostate-specific membrane antigen, which is a cell surface receptor, which is overexpressed in prostate cancer. And more, we are getting all these trials on pipeline that can really identify the specific cell surface proteins or receptors that are overly expressed in particular types of cancer. So traditionally, when you're doing metabolic imaging, you're looking for cancers which are necessarily high metabolism and high replication, but not all cancers are like that. So in cancers where you don't have that, we switch into receptor type of imaging. So even in prostate cancer, for example, about 80 to 90% of the prostate cancer patients overexpress PSMA as a receptor. But then there's still a percentage that doesn't. In those particular patients, either they have a more aggressive variant of cancer, and then in those patients, we can still use the metabolic imaging approach using FDG. So more and more in the future of this field, you will hear a term called multiplex imaging, which means we're multi-targeting different things in a single patient to try to create a comprehensive map of what's going on in not only receptor expression, but metabolic activity. And this type of information can trigger different types of therapies for the same patient in different locations, because the approach for tumors that grow slow and the approach for tumors that grow fast is not the same. So this is very interesting in the sense that you can really pinpoint different types of therapy for the same patient based on their imaging as a surrogate of what's happening.
So it seems to me that one of the important things would be to really use markers that differentiate tumors versus benign. So when you talk about PSMA, that prostate-specific membrane antigen that's expressed in 80 to 90% of prostate cancers, how common is it to see PSMA in normal prostate? Does that ever occur?
Yes, so that's a great question. Yes, so it does occur. It's just the density of expression that's different. So cancer cells traditionally overexpress the target. So when you have a higher density of expression of that target and you have circulating radioactive material in your blood that's attached to a receptor that will attach to the PSMA receptor, it will preferentially bind to locations with higher density, right? It will still bind to the normal prostate, but the intensity will be much lower. So you can differentiate that by the intensity of uptake, which translates into the a semi-quantitative method on imaging, where we can compare the intensity of uptake in specific organs with others. For example, we know that salivary glands have PSMA receptor. It's not super specific for prostate, but it is overexpressed in prostate. So in these other locations, we can compare that as a surrogate, knowing that it is usually hyperexpressed, overly expressed also in these other locations, and then try to understand what is happening. And then again, when you look at these and you're going to tailor a therapy based on that, of course, the side effects will be related to what we call the normal biodistribution, is how this agent distributes in normal versus abnormal cells. And the ideal target is always one that is only expressed on tumoral cells and less or almost not expressed on physiologic cells, although that is very hard. And I think the best example we have from that is the inception of this whole field of theranostics, which was radioactive iodine. Up to today, since the 1940s, it's been a landmark for metastatic thyroid cancer, for well-differentiated cancers, which it's basically only taken by thyroid tissue and not other organs, so the side effects are minimal, whereas you have a great benefit of treatment with these drugs.
Yeah. And so as we think about kind of expanding that field of theranostics to other sites aside from thyroid, so thinking about looking at things like PSMA for prostate cancer, can you tell us more about how this is really used in terms of therapy? Many of us may know a little bit about prostate cancer in terms of surgery, radiation, in terms of external beam radiation, even chemotherapy. But I think the whole idea of, using a radio-targeted scan for treatment of prostate cancers is a bit newer. Can you talk a little bit more about whether that is being used in clinical practice and for which patients?
Sure. So PSMA PET, which is the imaging part of this, was approved in the US in 2020. So we're still very early in the clinical use of this. But just to illustrate, before that, in patients who have newly diagnosed prostate cancer and underwent therapy, primary curative therapy with curative intent, and had whole staging with conventional imaging and were treated according to the guidelines, half of these patients would still have disease after a certain period of time. And we call those recurrences. And one of the things that's very striking is the number is very high. So why are you having all these patients not being cured when you're going for a curative intent? And it is obvious that we're just not seeing the size of the problem. So when PSMA came, it was so striking, the capacity of demonstrating disease in sites that we were not seeing, and the resolution is so incredible that it was adopted immediately. And we don't have yet numbers of how much it has changed the landscape of what's the numbers for curative intent after you scan these patients with PSMA. But right now it's been incorporated into the NCCN guidelines, which is this group of cancer centers that puts up guidelines updated every X number of years. And then patients with unfavorable intermediate risk and higher risk, which have a higher risk of not having localized prostate cancer, they all have this type of scan on baseline staging of the disease. So these are the patients that we're scanning upfront in the diagnosis of the disease. So this is widely used nowadays. It's not like trials anymore, the scanning part.
Perfect. Well, we'll talk more about actually translating this into therapies right after we take a short break for a medical minute. Please stay tuned to learn more about theranostics and advanced treatment options for prostate cancer with my guest, Dr. Gabriela Spilberg.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program is comprised of a team dedicated to managing the diagnosis, evaluation, and treatment of urologic cancers, including testicular cancer. SmiloCancerHospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anees Chagpar, and I'm joined tonight by my guest, Dr. Gabriela Spilberg. We're talking about Theranostics and advanced treatment options for prostate cancer. Now, many of us may know about PET, the nuclear imaging scan, which really looks at how cells take up glucose or sugar molecules. The idea, of course, being that cancers that are rapidly dividing, hypermetabolic, tend to light up on these scans. Some of us also may be aware of various other scans, thyroid scans, for example, that do the same kind of thing, looking at where cancers might be based on certain molecules that they tend to express or light up more than normal tissues. So before the break, Gabriela was telling us about how this has really started to be used in prostate cancer with PSMA PET scans. But Gabriela, I want to pick up the conversation going back to something you had mentioned before the break, which was now that next step of using this technology, not only for diagnosis to look at the imaging, but also potentially for treatment. So can you talk a little bit more about how that is being used, perhaps particularly in prostate cancer, whether there are particular patients that this is for, whether this is still in clinical trials and that kind of thing?
Sure. So in 2022, Pluvicto, which is a drug called lutetium-177 PSMA, was approved, FDA approved for clinical practice. So this is the Theranostics pair from the PSMA PET scans. What does this mean? Theranostics is the junction of the word therapy with diagnostics. So you use the scan to see where the problem is, the extension of disease, and comprehend what is going on. And then you get the same molecule and you just change the radionuclide. Instead of an imaging agent, you attach a therapy agent, such as lutetium-177, which is a beta particle, which is capable of causing single DNA strand damage. And then when the cell tries to replicate, it can't because the DNA is damaged and then it dies. So basically, it's delivery of a very targeted radiotherapy in the blood that reach specific cancer cells that you don't want them to replicate. So this is the concept of the therapeutic part of this agent. Of course, every new drug, when you start using in the continuum of cancer care, we always start treating patients who have already been through other kinds of therapy. So initially, when PSMA, lutetium-177 PSMA was approved, Pluvicto, it was approved for patients who had already had failed, who had disease that had spread outside the prostate, what we call metastatic, castrate-resistant, who had been treated with one androgen receptor pathway inhibition drug, and who had already had at least one line of chemotherapy, which is a taxane-based chemotherapy, which is more commonly docetaxel. So these patients who have failed these two lines of therapies and have a PSMA PET that is positive, these patients are eligible for this treatment. And this is outside clinical trial. This is daily practice use. And this is what we do on a weekly basis in the clinic. So we look at these patients in a very multidisciplinary fashion. We have weekly tumor boards, which are these meetings where multi-specialties involved in a disease-specific group. So for prostate, we have a prostate tumor board, and all these doctors meet and we review the patient's informations, and we elect which patients are good candidates for which drugs. So when you're talking Pluvicto, you really want a patient who has disease that is PSMA positive on the PET and doesn't have disease that is PSMA negative, because if you're targeting something that you don't see uptake in the imaging, you won't really treat with the therapy, which is the pair. So when you do these therapies, we're talking about a maximum of 6 treatment cycles. Each cycle is about 6 weeks apart, and that can be tailored for patients depending on how they do. So sometimes we extend these cycles into longer duration, or sometimes if the patients have great response and the tumor markers go down and then they're doing great clinically, we will take a break and save these other additional cycles for further down when they need. So we really tailor these things patient by patient. And then we treat the patients in the nuclear medicine infusion suite, and we work in conjunction with GU Medical Oncology and all the other providers which are also part in the care. And for example, if you have a patient that have one specific location of disease that is not responding to Pluvicto, and you image this patient and you find that it's a location you can maybe do some kind of minimally invasive treatment or localized radiotherapy, that's also an option. So nowadays, because these things are so targeted and the profile of side effects has improved so much from traditional chemotherapy, you can take this more personalized approach, or really site approach to different locations of disease. And what you always want to focus on is what to treat first when you have different types of heterogeneous disease behaving different. So when you're doing these treatments, the side effects compared to chemo are much lower. The most common side effects are usually some toxicity to the bone marrow. And one of the reasons is because usually prostate cancer spreads to the bones. So this is a location where the bone marrow cells are. And then when you're delivering radiation to that location, of course, you will have some effect into the normal marrow cells. Other kinds of symptoms that you could have as side effects, rarely liver damage, some kind of, if you have a high burden of disease, renal toxicity, because these drugs get out of the body through the kidneys. They cross the kidneys on their way out. And therefore, it's very important for patients to be very well hydrated during and after the treatments. And when they go home after the treatment, sometimes it's difficult to control how much hydration they're getting. So this is something that's really key, is to have control and have support for the patient so they can optimize the delivery of these therapies while in the hospital and then after. Because these therapies are radioactive, they require some level of radiation safety precautions, and we go over these in very close detail with the patients. Usually, we talk about limited contact with other adults in the household. And when we say limited, we're talking about prolonged exposure, which means more than 3 hours and within less than 3 feet apart for about 2 days. And then children and pregnant women, that's a little longer, that's about 7 days. But we're not saying that people cannot be seen or exposed to other people. It's just prolonged contact exposes other people around them to radiation that's unnecessary. So that's what these radiation precautions really mean. And it's very important to understand that these therapies are delivered in a multidisciplinary approach. So in between the cycles, the patients still see their oncologists, and we also follow them. So it's really a patient-centered and interactive partnership throughout multiple specialties to make sure that these are effective and we get good outcomes.
Yeah. I mean, it sounds like this really has a number of advantages in terms of, as you say, reducing the side effects because it can be so much more targeted, as well as the idea that potentially these therapies can get to places that other things might not be able to get to in terms of treating distant metastatic disease. So can you talk a little bit more about, when we think about how we sequence therapies, you had mentioned that this, perhaps because it's newer, is really being used in patients who have already been treated and have failed the first kinds of lines of therapy. Is it your perception that Theranostics is going to move into first-line therapy and treat patients with prostate cancer even before they have more conventional other modalities such as surgery, radiation, or chemotherapy?
Yeah, so that's a great question, and that's exactly where we are. Because all these therapies with radiation have toxicity that is not immediately measured, so radiation toxicity typically is cumulative. So the more radiation you have throughout your life and exposure throughout treatment cycles, the higher is the risk for side effects. So when you're looking at these things and how the trials are designed, what happens is to have results of these trials, which are long-term and in an earlier setting of treatment, it takes time. So there are multiple trials being run at the moment throughout the world. Really, this has really exploded as a new modality of treatment. It's just we have not had enough data out yet in the prostate setting to say that this is going to move earlier. But for example, in Australia, there's one trial where they did 2 cycles before surgery. And this was just published last year. So you don't have really long-term outcomes to state that this made a difference or not. They were looking at the liver dose to the prostate bed itself and ease of the surgery. But in a few years, we will. And my feeling is that we will move further earlier in the disease cycle, as it just happened with neuroendocrine tumors. It's been presented at GI ASCO earlier this year that Lutathera, which is the similar treatment for neuroendocrine tumors, was more effective than the standard of care for neuroendocrine patients as first-line therapy. And since then, that is now the new approach. So we expect that to happen. It's just we don't have the data out yet, but this is a very exciting field.
Dr. Gabriela Spilberg is an assistant professor of radiology and biomedical imaging at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.